Good evening, maybe good morning, sometimes good night, everyone. My name is Jason Roberts. It's a pleasure to be present and hosting this Antimicrobial Optimisation webinar. This is a really exciting webinar. This topic is very focused on paediatric care, and as many of you will know, those that work in paediatrics, this is a horribly understudied area for a group of patients that are very precious to us all, and those that we want to see have only but the best opportunities to succeed with their health. And so this is a really important area. Many of the presenters will tell you about the terrible outcomes and the ongoing persisting high morbidity and mortality rates associated with severe infections in pediatric patients. And so that really does highlight why optimization of the available drugs that we have is so very important. So I would like to acknowledge the sponsors of this event that make these education programs possible. So the University Hospital Nîmes in France, who is an education partner of ours at CRE Reduce, but also Pfizer, MSD, Gilead, and Baxter. One important note that I would like to add is that we take a lot of pleasure in being able to run these educational opportunities. So of recent times, of course, they've had to be in the form of webinars, and we're hoping to return to some in-person meetings in 2022. But the life of CRE Reduce has come to an end, and that's because the specific funding that came from the NHMRC, which is a health and medical research funding body in Australia, has come to an end for that centre. But something which is very pleasing is that a new CRE, which we are fortunate to lead again, has been funded, and that's going to be called CRE Respond. And our focus of this is that although we provide a lot of education through the Centre of Research Excellence activities, we also have a large volume of health and medical research that we undertake. And so through the next iteration of this Centre of Research Excellence called Respond, we are aiming to more strongly implement the findings of our first iteration. So that's something which we're really excited to do over the next 5 years. Of course, with that ongoing support that we have from the NHMRC, that will then allow us to continue to provide educational opportunities like this and others, as I'm sure many of you would have seen over the recent years. This year alone, we've had as many as 10 different educational opportunities. The final comment I'd make is that it is World Antibiotic Awareness Week, which is now commenced, and it is very nice to know that we are an important part of an Australian array of educational opportunities that are ongoing, not only run by our group, and we have a couple of webinars occurring next week, but also by NCAS, so the National Centre for Antimicrobial Stewardship, and other groups such as the Queensland Statewide Antimicrobial Stewardship Service. Details of those can be found on our Centre of Research Excellence Reduce webpage, which of course you would have had to have gone through to register for this. So with that, I'd like to hand over to Dr. Suzie Parker, if she is able to turn her camera on. Welcome, Suzie. Suzie is one of our star researchers here at UQCCR, and she has a very strong research program based at the Queensland Children's Hospital as well, whereby she's looking for innovative methods to ensure that we can deliver optimized dosing to pediatrics and neonates. I'll hand over to Suzie and wish our wonderful speakers that I'm really excited that we get to hear from tonight all the best for a wonderful session. But Suzie, please.
Thank you, Jason, and welcome everyone. It's lovely that you've joined us this evening. As Jason has said, we've got quite a program running out of the Queensland Children's Hospital where we're looking at antimicrobial optimisation and trying to find the best dose to suit. We've got quite a few questions in our Q&A, which we'll run through some of them now. I'm going to kick off with one for Tony, And so Tony, I'm wondering, have you ever encountered a patient scenario where you couldn't achieve target exposures with posaconazole or voriconazole, so you've changed to a different drug because even TDM couldn't solve the dosing challenge?
Yeah, absolutely. So, yeah, a good example recently, a good anecdote is we had a patient with a really nasty fusarium infection with MICs all above what's been described as the breakpoints for aspergillosis and Candida. And we just could not achieve target levels with giving voriconazole, despite measuring AUCs, using linear regression and Bayesian forecasting, increasing the frequency. We just had to switch, and what we switched to was acetabuconazole. And my recent experience with acetabuconazole is that it seems to be quite well tolerated despite giving quite high doses. So the acetabuconazole MIC to the fusarium was 8, for example, for our kid. And we were doing levels. We ended up giving 300 milligrams. So it was a 10-year-old boy with relapsed ALL, fusarium, CNS disease. We were giving 300 milligrams BD, and he didn't weigh that much, like 30 kilos or something. And it's only until that level that we were getting an AUC over MSC of 25, and he tolerated that quite well.
Yeah, excellent. Okay. Also, another question for you, Tony. Where can clinicians obtain isavuconazole in Australia? Is that widely accessible?
As in the drug or to do levels?
Yeah, yeah.
Oh yeah. It's TGA approved in adults, so every pharmacy should be able to get it.
Okay.
Admittedly, it costs a bomb. It's not cheap. It's not on the PBS, so there's some considerations. Yeah.
Okay. Excellent. So now the next question I've got is for Amanda. We've got a question coming in saying a lot of credence is given to MIC. So this is for you, Amanda Gwee. A lot of credence is given to MIC as a target. When a patient is debilitated and immune suppressed, does that affect the MIC or AUC consideration given the host's poor ability to mount a response? Did you have a comment there?
Yeah, so yes, a lot of the pharmacodynamic targets are based on the relationship to MIC, and you know, I think it's totally appropriate to do that, but the problem is that every lab and clinical service has a different way of measuring MICs, and all the gold standard pharmacodynamic targets are based on broth microdilution MICs, which are just never used in clinical practice. So but in a patient who's debilitated, does the MIC change? No, not necessarily. It would depend on obviously their prior exposure to antibiotics that may cause reduced susceptibility to the antibiotic. But would the drug target in terms of the area under the curve target change? Yes, potentially. So, you know, we know that in children who are more unwell, that we would need to, for example, beta-lactam's target concentrations a lot longer above the MIC in those patients who are immunocompromised or are severely unwell. So I hope I'm answering your question.
Yeah, and then that would then relate back to that the target side as well, wouldn't it? Of trying to get the penetration and concentration there. Yeah.
One thing I wanted to add to that, I think especially in the antifungal space, is that especially mold infections, zygomycosis, they destroy blood vessels. So despite you getting perfect AUC MOC target attainment, sometimes the mucor infection in the nose needs to be cut out because there's just no blood supply. So there's a lot of things that affect treatment outcome, especially in the IFD world. And, you know, it's the degree of immunosuppression, how much neutrophils they have, and ultimately for Mucor could be surgery.
Yeah. And jumping off that, obviously, where the site of infection is and how well antibodies penetrate that site. Yeah.
Okay. My next question we've got here is for Nicolette. I thought you might want to address this one. Given there are a lot of generic antimicrobials, are we protected enough against inferior products? Is there enough quality control at the consumer end?
Great question. Just checking my sound that everyone can hear me.
Yeah, maybe if you can yell for a little bit, that'd be great.
I do apologise, everyone. Look, I'm originally from South Africa, so this is actually a question that comes up quite a bit. I think pharmacovigilance and having a good medication authority in the country where you're working or treating patients is really important. And I think especially during COVID, we've learned that we often have to parallel import lots of generic products to be able to maintain supply. And I think when we discover that we may not be achieving, especially when we're doing therapeutic drug monitoring, the levels we would expect or anticipate in our patients, despite, you know, putting our heads together and asking the experts, you need to ask yourself the question sometimes, is there an issue with the product? So I don't think in Australia we've got a concern regarding that. I think we're fairly fortunate with the TGA and likewise for countries such as Europe and in the US, where they've got great medication regulatory authorities available that do that testing and quality control. But I think it is important for us in the era of antimicrobial resistance to consider that also as a question mark if you're not getting the exposure you're expecting.
Yeah, because I think the acceptance criteria for a generic is 80 to 125%. So you know, if you're talking at the 80% level, and then you've got patient